Jason, can you hear me?
Yes, Dr. Cooks, we can hear you.
All right, thank you. So it's noon. We're going to go ahead and get started. Thank you, everyone, for joining the session today. I, again, will always say that we are very pleased to present Lunch and Learn to you each month, Third Thursday Client Forum, or Third Thursday Virtual Forum it is. Today we're going to be talking about diabetes. Few things, if you have any questions or anything that you want to ask us after the meeting, please email us at virtualforum@wecaretlc.com, and someone will get back to you with questions upon that. We also have a few questions for you throughout the session so that you can have an opportunity to engage and enjoy the segment along with us. Today we have a very good stand-in for me, and she is going to be presenting, and that is Stephanie Barnes. And Stephanie is one of our regional nurse managers with multiple years of experience as a nurse and as a health center leader. I want to publicly thank her for taking on this task, and I'm going to turn it over to her as she begins to walk you through everything that we're going to talk about today related to diabetes. So Stephanie, I'm giving it to you.
Thank you, Dr. Cooks. And so we will go ahead and pull up the presentation. Jason.
It should be showing now. Are you not seeing it?
I'm sorry, I'm not seeing it on my side.
Jason, I see it on my side.
I've just reshared my screen, so hopefully you can see it now.
I'm sorry, Jason, it's still not showing on my side. I do apologize.
Stephanie, could you pull it up to share?
Yes, let me see.
On your end.
Okay.
And in the meantime, while she's doing that, I can see it. I'm going to just basically talk about the disclaimer again, that this is not intended to substitute for your PCP's information, but it is provided to provide supplemental information and education surrounding the topic of diabetes. And today we want to make sure that you're aware of risk factors and prevention strategies. Also know about diet and lifestyle modifications that help to manage diabetes should you have diabetes. And then basically go over some of the evidence-based recommendations for management and from day to day. So it's a lot of really good information. And as Stephanie is pulling up her presentation on her end to share, we'll just give her a minute to do that and she'll proceed. Well, I can ask the first question, jumping right in. How many people, and this is an audience participation question here, but how many people in the U.S. have diabetes? And so if you think it's 5 million or A, raise your hand. If you think it's 10 million or B, raise your hand. All right. Lower your hand, B person. If you think it's 30 million or C, raise your hand. If you think it's 2 million, raise your hand. All right. So Most appear to have said 10 million. Jason, can you go to the next slide, please? Exactly about 30 million. It's a startling number, but about 9.4% of the population has a diagnosis of diabetes or have diabetes. About 23 million are actually diagnosed, and about 7 million don't know that they have it yet. But typically, based on the data of when persons are formally diagnosed, many of them have potentially been living with the disease for a while and not know that they're living with the disease. So with that information and those statistics, that the estimate comes out to around 7 million that may be undiagnosed. And then there's 1.4 million new cases that are diagnosed typically each year. So it's definitely prevalent. It's one of the highest cost conditions in terms of the United States healthcare dollars spent on chronic diseases. So diabetes is one that it is most cases, or in many cases, it can actually be controlled as well. We'll get into more information about the types and then the control measures, preventive strategies, and then avoiding that diagnosis of diabetes, because there's a lot of times the early warning of pre-diabetes that gives an opportunity to do some lifestyle modifications and potentially change back or change the trajectory so that you're not fully diagnosed with diabetes. So I am Stephanie. Are you ready now to share? It's weird that you can't see the screen. Stephanie, you're on mute. All right. So, Jason, I'll keep going until I can hear from Stephanie. I was actually having her do it because I have a lot of background noise that's going to be picking up here real soon, so I didn't want to interrupt everyone with that. But I'll proceed until she's back on. Another question: which of the following is not a form of diabetes? Is it A, type 1 diabetes mellitus, which means that your body doesn't produce any insulin? It's also called juvenile onset diabetes or insulin-dependent diabetes. Is it B, type 2, C, type 3, D, gestational, or E, others, where there are diabetes related to other conditions? So if you say it's A, raise your hand. Okay, I don't see any A's. Any B? People think it's B. What about C? Okay, we see some C's. Then lower your hand, C's. If you think it's D, raise your hand. Okay, what about E, others? Meaning other types of diabetes that are driven from other conditions. Okay, well, the correct answer is indeed C, type 3 sugar-dependent diabetes. Some of us may recall, old verbiage for diabetes, me saying sugar, or I have sugar, or they have sugar diabetes. That's not an actual term, and there's never going to be a diabetes that is dependent on sugar. So that one would not be right. So if you said C, then you would be correct. All right, Jason, I'm going to go through the ABCs. And again, Stephanie, I know is trying to get on. She just IM me and said the system is not allowing her to get in. I don't know what's going on. And I will apologize in advance if you hear any background noise because, again, I am in a location where you may hear some from time to time. The ABCs of diabetes. Basically, diabetes makes you think about high blood sugar. But the basics are, it's a chronic condition, and it affects the body's or the pancreas's ability to produce insulin. So it's either having too little insulin or no insulin at all. And insulin is basically used to pull the sugar from the blood and use it throughout the cells and make sure that the body functions properly. So it turns the sugar from the blood into the cells for glucose, which helps us with our energy and day-to-day functioning. It affects 1 in 4 people over the age of 65, and about 90 to 95% of cases are in adults, and they have type 2 diabetes, which remember is not the insulin dependent one, but this is one that typically can be controlled with diet, lifestyle modifications and such. Next. There are varied risk factors. More people who are likely to develop type 2 diabetes are over age 45. Having a family history, of course, is important. It helps to know what your family history of any chronic diseases are, because it is definitely a precursor or predisposing factor for several chronic diseases. So I know when you visit your healthcare clinician, they'll usually ask in your first visit or in annual visits about your family history. It's good to know those things because it helps in guiding the providers in terms of what kind of tests and or type of education that they need to be prepared to work with you as an individual person on. Then obesity, inactivity is one of the things that creates a risk for diabetes. And minorities have a higher rate of diabetes. So it's very important, again, that when a person is of a minority race or ethnicity, that they should know their family history and look at their lifestyle risk, because it increases the possibility of them getting diabetes. Other health problems such as high blood pressure, kidney disease, these are called comorbid factors. So if you have other chronic conditions, it could potentially trigger a diabetic response as well. And then persons who were experiencing pre-diabetes or gestational diabetes. And I'm going to get into those again a little bit later. Next. Jason, can you? Okay, thank you. The diagnostic strategies, because type 1 diabetes can run in the family, there is a TrialNet study that offers free testing to family members of people with diabetes. So that's something that you can Google online to see how the test works or where you can get access to it if you have a family history of diabetes. And then, of course, healthcare professionals or your clinician will do the fasting, most people say fasting blood sugar or the fasting plasma glucose test. And the A1C, the hemoglobin A1C test, is really the biggest indicator for diagnoses of diabetes. And whereas a lot of time in the past, there was more of a reliance on the blood glucose or the blood sugar, the A1C, which basically measures your blood sugar over a period of 3 months, is more accurate in determining persons' potential for or predisposition for diabetes. And then persons who are pregnant typically have to take a glucose challenge test between 24 and 28 weeks, trying to identify the risk during that time, because when you get later in the pregnancy and tend to develop diabetes, it could lead to more severe side effects. So what is the fasting plasma glucose test? And that basically measures the blood glucose level at a single point in time. So it's before you eat, typically 8 hours since your last meal. Most people are going to do this first thing in the morning, and its most reliable results are in the morning, actually, before you eat anything. So anytime you say fasting, of course, that means before you've eaten or drank anything. And some people will eat ice chips or sips of water. And again, the sips, not chugging a whole gallon or half liter of water, but sips here or there when you're fasting, and that doesn't seem to have any impact on the fasting glucose score. So from FTG to A1C, so we talked about the fasting plasma glucose. The A1C test, as stated, it gives an average of blood glucose levels over the last 3 months. And some people call it we used to, when I started nursing about 30 years ago, it was always just hemoglobin A1C or HbA1c. But now in the medical terminology, we've seen them drop the hemoglobin or drop the HB and refer to it generally as A1C, and everyone understands what that term is. You can eat or drink before this test because it's not necessarily related to your fasting or what you had an hour or two before, because remember, it looks at the average over the last 3 months. And the test, there's some potential inaccuracies for persons with anemia have different hemoglobin levels than persons who are non-anemic. The fact that their levels may be low in itself. So A1C, if a person has anemia, and usually the provider asks these questions beforehand so that they can ensure that the results that they see are considerate of the potential to be impacted by their anemic diagnosis as well. The tests are reported as a percentage, such as 7%, 6.5%, etc. And the higher the percentage, the higher the average blood glucose levels. We don't want to see extremely high blood glucose levels or high A1C. But there is, again, with type 2 diabetes, which is the most prevalent with type 2 diabetes, if you have a high A1C, there is a way, medication sometimes, but in many people, just the general lifestyle modification is helpful. Okay, so what does FTGs and A1Cs mean? We talked about this again. Wanted to let you see a chart of what's considered normal and then what's considered pre-diabetic and diabetes. So when we say pre-diabetic, that means that your scores or your lab results, whether they're your fasting blood glucose or fasting plasma glucose, or your A1C level, if either of those are in a close to high range or at the points that you see here, then you're considered to be in the pre-diabetic phase and have an opportunity in most cases to change the pathway and make sure that you avoid being diagnosed with diabetes itself. So for A1C percentage, normal is below 7. We don't. Most doctors want to see a 6.5 range. At least if you're diabetic, nothing higher than that, but 7 is the newer norm that's acceptable. So some cases you'll see the information say 6.5, and others you'll see 7. But generally, we want to keep it below 7 in all cases, and where your fasting glucose or plasma glucose level is concerned, 99 or below is the intended target. And then the oral glucose challenge test is when, I don't know if anyone's ever had an oral glucose challenge test, but it's when you drink this really, really sweet drink, and you basically wait a while and then check your glucose levels and see how much it's been impacted by drinking this sugary substance. And some people who have hypoglycemia, interestingly enough, their blood glucose level will not move. I actually have seen people who have spent a whole 8-hour period doing their hourly glucose tolerance, and they start out with a blood sugar or blood glucose range of let's say 75, and after drinking sugar all day, it's not moved up to more than 80. So that just shows that they have a different issue going on, where theirs may not be, diabetes from the standpoint of treating for high blood sugar, but looking at other ways to treat the fact that they have low blood sugar for some reason. Then if they're pre-diabetic, this is the range usually when somebody is 5.7 to 6.4, you're okay, pay attention to what you're doing. Let's make some modifications and changes and move back. For fasting blood glucose, that is going to be 100 to 125. And then for oral challenge, you have the 140 to 199. But when your diagnosis is why I said for the what providers want to see after you have diabetes, they want to see you at 6.5. Some of the charts say 6.5, some say 7. But any time that your rate is 6.5 or above, in most cases, they're going to deem you to be diabetic, because it indicates over the last 3 months you had a high rate of blood sugar consistently. And for the oral challenge, it would be anything over 200. And fasting, if your blood glucose or plasma glucose is more than 126 and you haven't eaten anything, that's a sign that you may have some type of insulin issue with your insulin production. All right, so diagnosis of type 1, we talked about this one. It's when your own immune system attacks the insulin producing cells, and the body does not make any insulin at this point. This is what a lot of children deal with. They have to take insulin. You see a lot of insulin dependent children with the insulin pump. Most people who have type 1 or insulin dependent diabetes are diagnosed as a child or as a young adult. When we get into type 2 next, we're looking at mostly a mature adult population, even though as we're seeing trends in healthcare shift a little bit, some are younger and being diagnosed with type 2, and it's associated again with the poor lifestyle, the dietary and exercise habits that are not conducive to burning enough energy and making sure that the body remains in optimal condition to avoid chronic illnesses. That's when the pancreas just says, I'm gonna take a break and see if what I can get away with in terms of insulin production, and it doesn't produce enough. And it causes issues with being able to pull the sugar from the blood. And in some cases, persons with type 2, well, in a lot of cases, persons with type 2 diabetes end up having to take insulin. Most start with metformin or something to that degree, but many progress to insulin if they're not able to make the changes in their lifestyle and diet to ensure an adequate blood glucose or A1C rate. Next. All right, pre-diabetes. This is what I call the early phase. And again, it can be managed with diet, exercise, and monitoring of blood sugars. It can also prevent the full development of type 2 diabetes. So once you know you're at risk and you're getting that initial warning sign, that's a good opportunity to say, okay, do I want to go full gear into diabetes, or do I want to stop and make the changes I need to avoid having to be dependent on medication or dependent on insulin? I've seen many people change their entire lifestyle after being diagnosed with prediabetes and have never transitioned into the diabetic state. So it is possible, because in the case with type 2 diabetes, and it is something that can potentially be controlled. Next, gestational diabetes is kind of, I call it the luck of the draw for persons who are pregnant, because it's not a lot that you can do to become diabetic at this point or to avoid diabetes at this point. Is something that, is like drawing the short straw. But it's when the high blood sugar just starts to develop in pregnancy, your hormones or what your system and cells are definitely not, functioning as they usually would do, and kind of hyperactive anyway during pregnancy for the most part. And this is one where it's not as easy, even though we say we can control it by eating healthy and staying active. My experience and a lot of evidence supports that many people who have gestational diabetes basically ended up with the luck of it. It typically resolves after the baby is born, and it can increase risk for complications during pregnancy, which is why it's so important to take that test in the 24th and 28th week. We don't want to make sure that as you get into that last trimester, closer to delivery, that the risk is not identified earlier. And the other thing is, if a person develops gestational diabetes, the potential to develop diabetes later in life increases. All right, so here's a question. Which form of diabetes is less likely to occur as a result of poor diet and exercise choices? Is it A, type 1 diabetes, where there's no insulin production? Is it B, type 2, or C, gestational? If you think it's A, raise your hand. All right, if you think it's B, raise your hand. If you think it's D, raise your hand. I mean C. Skip C and went to D. Make one up. I didn't see every hand, but the correct answer is A, is type 1, because that's the one where is the person's genetic makeup and their body is just not producing insulin. So their diet and exercise is not typically the contributing factor to that diagnosis. Signs and symptoms, there are many, but most will say, I get really thirsty, or I have to use the bathroom, have to urinate a lot. A lot of people are urinating at bedtime more, just hungry and can't figure out why. Tired. Blurred vision is a really good one because a lot of people seem to have vision distorted. And as we all know, glaucoma is one of the risks with diabetes as well. So it definitely does impact vision. Some people have numbness or tingling in their hands and feet, or sores that do not heal. Diabetes impacts the ability for the cells to regenerate and heal properly. So some have that issue with sores that don't heal. And then unexplained weight loss. So preventative strategies are regular checkups to monitor blood and blood glucose and A1C levels, good eating habits and regular exercise, and then remaining tobacco-free. Don't start smoking, and if you smoke, quit smoking. Those strategies will definitely help minimize the risk of diabetes. Getting at least 30 minutes of exercise 3 days a week is good. Sometimes just meditation and yoga, even the lightweight type of exercises are good. All right, here's another question, and you're not required to share, but if you are okay, raise your hand if you or a family member has been diagnosed with diabetes. All right. Keep your hand raised if they were diagnosed with pre-diabetes in advance. Okay, interesting. All right. So again, with that pre-diabetic phase, it gives you the opportunity to make some changes and avoid moving over into diabetes. So I would say be very attentive to your lab results when you go to the doctor and get your annual exam. I am a big proponent of encouraging your annual exams and your annual lab and looking at your A1C to see what level you are. And if you are known to be in that range where there's a risk of diabetes, make the changes now. All right, manage your diabetes A, B, C. A is the A1C test. We talked about that. B is blood pressure because most people with diabetes have blood pressure issues or have a potential to have blood pressure issues as well. So ask the doctor to determine your blood pressure goals and control the blood pressure via diet, exercise, and medication where adequate. Next, cholesterol. Monitoring the intake of cholesterol is looking for fatty foods. That is important as well in managing the diabetes. S is for stop smoking. So you'll see ABCs, A1C, blood pressure, cholesterol, and stop smoking if you do smoke. What else can be done to manage diabetes? Follow your plan. Follow the meal plan. I remember when I first started nursing, we used to know almost every different route to the different types of meal plans, a 1,000-calorie diet, a 14, a 12, 1,800 calorie diet. So know what your calorie recommendations are, working with your provider to get a good idea of what your meal plan should look like. Knowing when to eat what you want to eat, because there are ways that you can eat some of your favorite foods with diabetes and still not be at risk or in danger. You just have to know which foods are appropriate for your body based on the way that you're responding to the diagnosis. Making physical activity part of your daily routine, trying to work out again and 30 minutes or more, and then walking, swimming, just getting up and moving a little bit more. Taking your medicine if you are diabetic take the medications, and then check your blood glucose levels as frequently as recommended by your provider. Recommended targets for blood glucose levels, again, before a meal, 80 to 130. I think 130 is really on the high side because that basically says that your blood glucose is not as, or your diabetes is not as controlled as it should be. What I used to tell patients is under 100 is really where you want to be. But 120 is definitely the most you want to be before breakfast. But some of the information you see today will say up to 130. You want to eat have about 2 hours, or about 2 hours after you're eating, it would be less than 180. If you are having a low blood glucose, and it's below 70, then you really need to talk to your doctor about your plan. You need to talk about eating more frequent meals to see how that can help you to maintain your blood glucose over time. And then consistent high blood glucose can require medication or insulin therapy. There are various medications. It would be difficult to get into all of them. Most of us are familiar with metformin. Those with type 1 must take insulin because the body can no longer produce insulin. And those who do not, want to be stuck from day to day with their own individual needles, most of them have the possibility of using an insulin pump. Type 2 diabetics may need medications that are typically going to start with the pills, as I said, like metformin, and then some of them actually progress to insulin that's based on their blood glucose level. And there are some non-insulin injectable medications that help to reduce the blood glucose levels as well. So you would need to talk to your provider about whether or not those are effective or sufficient for your condition. Next. Quick question. Can I eat my favorite foods if I have diabetes? If you say A, yes, raise your hand. B, no, raise your hand. Or C, depends on the favorite food, raise your hand. Absolutely. It depends on what you want to eat, because some things, if they are very intense sugars and you have a high blood glucose level, you definitely won't be able to eat candy bars and ice cream every day. But you might be able to make a substitute for some of the other foods that you like to eat, working with your provider to adjust your meal plan. Next. What foods can I eat? There are foods with heart healthy fats that may actually help. And you want to look at, nuts, seeds, tuna, mackerel, avocado, those things. And then you use oil when cooking food instead of butter. So that helps as well. Next. What should I limit? So, of course, fried foods high in salt, sweet, cakes and pies are not going to be good. Ice cream and candy is not going to be good. And you want to try to drink water instead of sodas. And you want to drink alcohol moderately. If you do drink alcohol, for females, it's typically recommended that it's no more than 1 drink a day, and 2 if it's a male. And then talk to your doctor about when you should eat or drink, because that, again, helps to control your diabetes. All right, impact on other conditions. There's heart disease, stroke, kidney damage, nerve damage, and many others that if diabetes is not effectively managed, they create comorbid factors. For stroke, of course, it raises the blood pressure, and then the high blood glucose levels contribute to the fatty deposit or atherosclerosis, which does not help in terms of moving your blood through your system easily. And of course, the clogged arteries are one of the things that lead to stroke and heart disease. For kidneys, it's much the same because the kidney's ability to filter waste products is diminished with diagnosis of diabetes. So when your doctor does your urine sample and looks for microalbuminuria, and then kidney disease, of course, is called diabetic nephropathy. So anytime you have a kidney involved, it's a nephro. And if a person is developing kidney disease as a result of diabetes, it is diabetic nephropathy. So it's important when you're diabetic to make sure that you have your labs done so that these levels can be assessed every year at minimum. And they should actually be assessed a little bit more frequently with any chronic disease. For nerve damage, some people I'm sure you've heard of that have neuropathy, or they talk about tingling in their legs and feet, and they have, they can't feel cold and in their extremities to some extent. And also they have retinopathy, which is also a nerve damage, and that can lead to blindness. Again, we talked about glaucoma, but retinopathy as well, which is affected by the nerves, which are the nerves being affected by diabetes. Is diabetes able to be cured? Well, I already have the answer here. But even though it has no cure, steps can be taken to manage and stay healthy. Pre-diabetes or borderline diabetes, it provides an opportunity to avoid, again, full diagnosis. So there is no cure after you're diagnosed. It's basically management. So if a person who has diabetes gets to the point where they are able to manage their diabetes, it's just the person who's managing their diabetes. It doesn't mean that they are cured. It means that they are properly managed. This one you can't see very well, but I would suggest that you go online at some point and look up the diabetes risk test and see what your scores are, because it does give you a good idea. It's really one of those tools that gives a good idea of what your risk is and whether or not you will be able to function or need to do more in terms of your assessment and your provider communication. And that basically is the end of the diabetes information. I hope you found it helpful. We talked about the preventative strategies. We talked about the importance of exercise and diet, as well as just knowing your risk. Also, the different types of diabetes. Some, as you know, the type 1 is one that you have little ability to control, but the others, we have an opportunity to have some impact on how our body responds, and the ability to prevent the diagnosis of diabetes if we take heart to the diagnosis of pre-diabetes and begin to make changes and modify lifestyle behaviors prior to going forward into full-blown diabetes. If you have any questions, please place them in chat or email to virtualforum@wecaretlc.com. We thank you for participating and attending the meeting today. We look forward to you attending in our next meeting on the next Thursday. And again, as always, we appreciate this opportunity to lunch and learn with you. Have a wonderful day, everybody.